am pleased to actually introduce two of my colleagues. One is Dr. Rachelle Crescenzi, and the other one is Casey Grosinger. Dr. Crescenzi is a translational imaging scientist and director of the SALT lab here at UVA, where her NIH-funded research focuses on advancing non-invasive MRI techniques to better understand lymphatic function, sodium storage, and vascular disease pathways in conditions such as lipedema. And Casey brings more than 2 decades of experience in project management and communications, along with a deeply personal perspective as a patient living with lipedema and its related condition, and is a strong advocate for increasing awareness of these overlapping diagnoses. She's also a very active member in our patient advisory group here that we've put together. And together they're going to bring some of the perspectives across translational research and patient advocacy as we explore the relationship between lipedema and the Ehlers-Danlos syndromes. So, Casey and Rachelle, thank you.
Thank you so much. We've done this before. Okay, thank you so much. I'm going to invite you today to wonder with me, is there a connection between lipedema and EDS? But I'm not going to answer that question today. I hope we wonder about it for a time together at this symposium and after this meeting. I'm really, really thankful to Ina and Dacre for inviting me. It's been a pleasure to meet them over the past year. I'm also new to UVA, so my story with lipedema started in 2016, so I'll start my research, results will start there. I just want to disclose I work with the Lipedema Foundation closely as a scientific advisor, thankful to be on that committee, and our funding is from the National Heart, Lung, and Blood Institute and the Lipedema Foundation. The data that I'll present to you from our research results isn't meant to inform an individual's medical care, so just making that disclosure ahead of time. I hope to share with you today the challenges of lipedema, and I see a lot of themes and similarities with the story of EDS, so I'm curious what you all will see in our story. I will present our SALT MRI approach to understanding lipedema and invite us to translate together where we find some connections. So in 2016, I was awarded a postdoctoral fellowship to apply imaging to lipedema. And at a meeting with clinicians, this was at Vanderbilt University Medical Center, one of the physicians asked me, "Where are you going to find patients with lipedema?" And I said, "I thought that was what you were here to do." And I didn't know after that. So we went to the patient conferences and heard about their stories and what symptoms mattered to them. And we developed a brief survey, and I sent it out on social media after IRB approval. And I got 400 responses in 2 weeks. And I thought, this is a really engaged patient community. And I've been engaged ever since. That was an incredible response. And in this community, we're still seeing those kind of responses. A few years later, we built that up into a partly diagnosed cohort, and we developed a survey from 707 participants. And those results initially showed us that the most common symptom that troubled patients was pain, and that on average between 0 and 100, patients are reporting daily pain levels of 53, so over 5. When asked, according to patients, where they experienced their pain, they responded with disproportionate experiences throughout their body, which mainly focused on the lower extremities. So the primary pain was experienced from the hips down, but sparing the feet in relation to the rest of the legs, some in the upper arms. If you asked about other symptoms in lipedema patients, such as fat deposits or swelling that bothered them across the body, those symptoms were also focused on the lower extremities, a slight prevalence in the upper arms, and in the calves, and is where we're going to image. So across the calves, all these symptoms were noted. So we are going to focus there on imaging. But one story we were hearing is that the feet are spared in lipedema, and that may be true of the feet, or of the fat tissue. But this data showed us that swelling and pain symptoms are experienced in the feet of people with lipedema. And so overall, what we learned from the patient surveys is that this disease is one characterized by disproportionate fat, disproportionate swelling, and disproportionate pain. According to physicians at the time, this is the standard of care for lipedema in the United States, put together by a group of experts led by Dr. Karen Herbst, who's an incredible mentor and educator in the field and taught many of us about this disease, lipedema. These are her examples from the clinic that are published here across what's called stages of lipedema. And one of the primary criteria is that it is a distinct distribution of pathologic tissue that differs from non-lipedema obesity, and that is according to physicians. Here's a case example by photos of what this might look like when a patient presents to a clinic. On the left is a patient with lipedema, and on the right is someone with obesity determined by their BMI. And the lower extremities may appear different in these two cases because this is quite a characteristic case of lipedema. Compared to irregular obesity, lipedema has a gynoid fat distribution, has ankle cuffing, which you may see in this example, has a leg girth that's resistant to metabolic treatments, including bariatric surgery. The fat is typically painful. It exhibits easy bruising and has a lower prevalence of metabolic disease despite high BMI. Yes, you get the connection I'm hearing. So this is compared to common obesity. There's other symptoms that are more troubling to diagnose in the clinic as well. There was a term called lipolymphedema that was used at the time. And this is when lipedema has progressed to clinically identifiable lymphedema, or insufficiency of return of the fluid in the lower extremities by the end of the day. And this was seen in increased stages of lipedema, according to physicians. And so in a clinic, this is what it might look like. We have a patient with lipedema and a patient with cancer-related lymphedema, where you know the cause of lymphatic insufficiency. In the person's affected extremity with cancer-related lymphedema, it looks an awful lot like lipedema as well. It's larger than the other. It has a texture to it when you palpate it. There's even an ankle cuff on that person's leg. So when someone doesn't have an identified cause of lymphedema, they're usually called lymphedema in the clinics. It could also be lipedema. We're trying to help differentiate these two. So this represents a challenge in the field. Compared to lymphedema, in a clinical setting, lipedema can be characterized with an ankle cuff, a bilateral leg swelling presentation, feet that are often spared, and lymphatic insufficiency symptoms that are suspected but may not be confirmed. Those were demonstrated. And these are the challenges, are to distinguish lipedema from obesity or lymphedema in a clinical setting. The etiology remains unknown, and we need to understand that. And this is a similar story we're hearing. The symptoms may have onset at times of puberty or pregnancy or changes in hormonal events in patients. That may be on an average age of 10 to 19 years of age where symptoms are onsetting for lipedema. But the average age of differential diagnosis, according to a US population survey and a UK survey, is not until 44 to 48 years of age, which is a 20-year gap in diagnosis. And that's a benchmark that we need to use as something to improve, and I think we really can. What we need are objective tools, though, to help differentiate lipedema from obesity, to study disease mechanisms, and to evaluate therapies. So I'm going to share with you some evidence from the first, or speaking towards the first aspect of this, using our imaging approach. So I'm an imaging scientist and love magnetic resonance imaging because it's non-invasive. And so this is our tools. We use an MRI scanner, which you may or may not have seen before, but it's a large bore scanner, and it has a detector for the anatomy of interest. And I work together in a great team. So this is our current team from 2025. Okay, our approach is called SALT MRI. If we have time, and you're welcome to ask me, why sodium? But suffice it to say, we're interested in where sodium is in the body, and we can image it with MRI non-invasively. We also think it's interesting to study it alongside the adipose tissue distribution and the lymphatic function in the body. So we're seeking to do this in a non-invasive approach. So next I'm going to show you some results from individual case studies in using these techniques and group level results, and then move to translation. So starting with our first type of imaging, this is a fat-weighted MRI or adipose tissue-weighted MRI in a whole body approach. I'm showing two case examples. On the left is a healthy female with a BMI of 24, and on the right is a patient with stage 1 lipedema and a BMI of 25. And these participants have similar BMI in this case. We performed whole body MRIs because we didn't know exactly where to start with lipedema. We thought the lower extremities might be the most interesting, but what if that wasn't the case? And we wanted to study the distribution. So we wanted to know what upper body fat distribution was compared to lower body. But if you would just observe the bright areas of the image, that's where the adipose tissue is located. You can compare between the waist level here, and if you scan down all the way through the legs, you might notice that the participant with lipedema has a thicker amount of subcutaneous adipose tissue that starts about the hips and continues throughout the legs. Then the examples on the right are looking at just the level of the calf. A transverse image shows the fat-weighted tissue on the top and the water-weighted tissue on the bottom. And if you take the volume of those bright pixels in each of those two images, So the amount of fat tissue volume or the water-weighted volume, which is essentially the muscle, and you take the ratio of those two, the participant with lipedema has 3 times as much fat to water ratio as the healthy participant with a similar BMI. So we thought that was interesting and analyzed across the legs in a small cohort, but a pilot cohort of people with lipedema and people without. We found that in every decade or every 10% of the leg height, there is a higher level of subcutaneous adipose tissue volume in people with lipedema compared to a cohort with similar age, BMI, sex, and race. And we found that in the upper thighs is the most distinctive region to look when you observe with this biomarker. That was published by an excellent graduate student in the lab and was a lot of fun to do this study as an imaging scientist and find a potential distinguishing marker of lipedema. We moved on to look at tissue sodium in an upper and lower body approach. So again, in the upper body, I'm showing in the middle column here what forearms looked like in people with lipedema, and on the right, images from the calf. In this case example, we're comparing a patient with stage 3 lipedema compared to a healthy female. They're within a decade of life, and they're within 5 points of BMI of each other. You can observe that in the forearms, there's a similar amount of adipose tissue distribution in the forearm, and there's a similar amount of tissue sodium as well in the colorized image. If we look at the calf, however, there's a thicker amount of subcutaneous adipose tissue where that arrow is pointing, and there's higher levels of sodium throughout the leg. This is a colorized image that's quantified into the physiologic range of tissue sodium between 10 and 40 millimole per liter. And the red and yellow parts of the image show higher deposition or storage of tissue sodium. And that's occurring in this patient throughout their skin, their subcutaneous adipose tissue, and their muscle. That's a case example, and here is a pilot study looking at those effects as a group. We're comparing here controls with similar age, BMI, sex, and race compared to a group with lipedema. And we found that in the calf, in the skin and the muscle, there were distinct amounts of tissue sodium storage, and that was not true in the arms. So here we're looking at a distribution of sodium throughout the upper and lower body, pointing to the lower extremities being more affected by storing more sodium. Our third technique that we were interested in piloting was a non-invasive approach to look at lymphangiography or tissue edema throughout the lower extremities. And we think this relates to where sodium and where adipose tissue is going to develop for a lot of reasons. And we're interested in understanding this across the spectrum of lymphatic diseases. We did some early work in simulating and developing this technique in true lymphedema, where a known cause of lymphatic insufficiency is occurring. And then we applied it to lipedema. I'm just going to orient you on what the image shows here. On the left is the adipose tissue weighted imaging that we've been looking at, where white means a lot of adipose tissue. The image to the right of it, the bright parts of the image now relate to tissue edema or fluid that's moving slowly. And you'll see that fluid is in the bladder, it's in the synovial joints, in the knee, but it's also throughout the tissue in this participant. You can also see in this 3D view that it has tubes and channels, and they traverse into the lymph node territories where we might expect a lymphangiography to show. So we're working actively still to develop more quantitative and whole leg approaches to analyzing those hyperintensities or those bright parts of the image, because we think they show us important parts of where the lymphatic system is accessing. To do that, we really need better tools to segment or analyze our images in the legs. I will say, as an imaging scientist, there's a ton of development in brain neuroimaging doing segmentation, and there's a lack of development in the extremities. I have no idea why. I think the majority of people I ask in my family, they have issues in orthopedic, areas, not necessarily in the brain. And so I don't know, I just find it really interesting that there's a lot of focus on brain image segmentation. Maybe it's that the legs are harder. I don't understand it really. So this to me is a circle, a lot like the brain. If anyone's interested in helping, we'd love more help in this area, right? It doesn't seem that difficult, but I will say there's not great tools. So AI has really made a lot of development and help with image analysis, because it's inherently, images are inherently matrices, just like these networks are training on. Anyway, it's exciting. We could go into this more, but I'm really thankful for some help and collaboration here between radiologist Klaus Hegspiel, Nick Tussison in radiology at UVA, and a fantastic graduate student, Zola Bizdek, in physics. And together over just the last year, they've helped develop an automated tool to segment our images and apply them to the lymphangiography. Sorry, thank you all for listening to this part. I think it will make a difference though, because there's a lot of misunderstanding about edema and whether lipedema is an edema or a lymphatic disease. people are maybe more willing to understand lymphedema because it has the lymph in it. And so we're looking across different case examples here and what imaging can help us understand about these conditions. So in a controlled participant without a known lymphatic insufficiency, in lymphedema where there's a cancer-related cause to their edema, in a patient with lipedema where there's no otherwise cause of edema, and in a person with lipedema and symptoms of lymphedema where they have unresolved swelling by the end of the day. And on the lymphangiography image to the far right on the gray level scale, you might observe those hyperintensities are more intense in the lymphedema case and lipedema with lymphedema. So now we start to see positive controls coming out in the data set qualitatively. And our lipedema case, not yet with full-blown lymphedema, has hyperintensities as well. And it's throughout their subcutaneous adipose tissue. And we want to understand where that's developing and how it's characterized differently. So to do that in a quantitative way, after we see it with our eyes, can we measure it with a number? And that is what something called texture analysis does. And so these are some typical texture features of images called energy, entropy, or homogeneity. And we're going to get excited about these in the lab soon. So I share this with you. It's unpublished new data, and we're really excited to keep pursuing this together with radiology and understand how to characterize edema in lipedema. And I really am curious what the EDS community will see in this. But here's the start of a larger scale diagnostic model study. This is funded, started with the Lipedema Foundation Pilot Award and was funded for 5 years by the NHLBI. And some of our initial results of that study are here. We gathered 65 people with diagnosed lipedema compared to 33 controls. And we took an MRI approach and a bedside approach to objectively quantifying characteristics of disease and seeing if we could help develop a model that would aid a clinical diagnosis based on just objective tools. And if you use MRI, what we showed is an area under the curve of 0.82. And if we use a bedside approach, we can achieve an area under the curve of 0.77. So we're a little bit more sensitive on the MRI side, but we can get by with a bedside approach that might be more appropriate for a physical therapy setting, for instance. And I can explain more about these tools and metrics and would love to talk with folks who are interested in that in other disease models. But we're really excited to be pioneering biomarkers that can help aid diagnosis objectively for lipedema, and we hope it makes a difference. I want to just end with a call to translate together. My work really sits in the T1 and T2 levels of translation, where it's first in human or first in patient applications. And I'm excited to work together at UVA with basic science researchers and those in public health and in practice to really translate our findings to make an impact across healthcare systems. And so this is just a slide to present and acknowledge our team here. I work with a slew of imaging scientists and radiologists, but together with us today is Sarah Algoodban. She's a basic science researcher in adipose tissue biology, working in the plastic surgery department here at UVA. We're excited to have her too. She's a long timer in lipedema, which is like for 10 years. And so excited to work together with Sarah at UVA. We also work closely with Allison Scott, who's a public health scientist in the lab and is developing quality of life. Well, I'm going to show you what they're developing. So we will hold on that. Okay, first of all, in basic sciences, Sarah's pioneering characterizing the tissue, looking particularly at microvascular disease mechanisms of sodium storage. And this is developed with our plastic surgery partners. And in the public health realm, Allison Scott is pursuing ways to identify clinical staging and quality of life, and also barriers to treatment and the medical syndemics of lipedema. If you'd like to participate or help her survey, she needs people with and without lipedema to respond. And this is really related to the WHO Quality of Life Validated Survey Questionnaire across 6 domains of health. And one connection that I see in a way that we could translate together in the EDS community is, I just want to share initial observations that there seems to be an overlapping criteria or an overlap in symptoms between people with lipedema and those with EDS or HEDS or HSD. And so in some of our survey studies, we found that women were 12 times more likely to have joint hypermobility in the lipedema cohort compared to controls. And then some involvement in the international consensus work that I've been helping with across different with different medical professions, patients, and researchers. This was our Lipedema World Alliance Delphi study, and we found in statement 26 that there was 75.8% agreement that there is an association between lipedema and hypermobility spectrum disorders. There's also a hypothesis put forward to call this a subtype of lipedema when hypermobility of the joints is present. It's called a really fancy Latin word called rusticanus moncor type. And I really enjoy hearing that from the physician community. And so I would love to hear more feedback on this subtype of lipedema that has hypermobility of the joints and what kind of criteria work we can develop together. Can we be asking the same questions of our patients and developing good diagnostic tools together? I just want to throw out there that as I look at the lipedema library, this is curated by the Lipedema Foundation, and it's my favorite library tool to look at. There are 2 published studies that show up when you search for EDS, and one is by Dr. Francomano, who was just here. And so I'm highlighting their work that we're speaking the same language. She's got radiology in their report. They took an ultrasound approach to look at subcutaneous tissue, and there's a lot we could do better with imaging tools to understand these diseases. So I would love to do that together. I just want to share that we're piloting ongoing research into objective biomarkers. This is in partnership with the Lipedema Foundation and NHLBI. There's 2 ongoing studies at UVA to apply imaging tools to study lipedema and lymphedema. These are going to then develop into a longer study that we hope to continue for a long time here. So email us, take the survey if you want to enroll if you're local. And I'm going to pass it off to Casey Grosvenor, who's going to share with you her personal story as a good friend of ours and mentor in the field.